Yes, we are live now.
Okay.
Good evening, everyone. I am Dr. Maunika. I welcome you all for today's session. And before starting the session, I would like to give a brief introduction regarding our speaker, Dr. Kavita LS, and she is going to discuss about tubal factor infertility evaluation and management. Dr. Kavita LS is an MBBS, MS, DNB, and DGO. She is a senior consultant obstetric and gynecology fertility laparoscopy at Kattanam Medical Center, Kattanam, Kerala. She's a managing director in Sri Krishna Hospital, Thiruvananthapuram, Kerala, and director of Sri Krishna Center Fertility, Indivar Medico Private Limited, Thiruvananthapuram. I welcome you for today's session, ma'am, and I hand over this session to you.
Thank you. Thank you so much. Thank you. Good evening, all. The topic of today is tubal factors for infertility. It's evaluation and management. So this is a common cause of infertility in the modern years. So the topic, what is the need for evaluation? So we'll see the need for evaluation of how we diagnose infertility. So diagnostic evaluation for infertility is indicated for women who fail to achieve a successful pregnancy after 12 months or more of unprotected intercourse. Since approximately 85% of couples may be expected to achieve pregnancy within this interval without medical assistance, so evaluation may be indicated for as many as 15% of couples after this period of time. So coming to the causes of infertility, the most common cause of infertility is, as you can see, it is ovulatory causes. So that accounts for around 27%. And the rest of the causes, if we set apart the male factor, that amounts to around 25%. Tubal factors comes to around 22%. So that means that this is a topic for discussion. And the other causes are unexplained factors, endometriosis, and some other reasons that will come to later. So in a study that was conducted by the WHO, the most common identifiable female factors, which accounted for 81% of female infertility, was ovulatory disorders that amounted to 25%, tubal factors that amounted to 11%, other tubal abnormalities like abnormal knot blockage, functional problems of tube, saculations, adhesions, etc., amounted to around 11%. Pelvic adhesions amounted to 12%, and the reason for infertility because of endometriosis came to 15%, hyperprolactinemia 7%. So we'll see what is the importance of fallopian tube in fertility. The fallopian tube plays an important role in the mechanical transport and physiological sustenance of the gametes and early conceptors. It provides a route for the transport of gametes and the early conceptors. The complex and coordinated neuromuscular activity, ciliary action, and endocrinological secretions are required for successful tubal function. So actually, fallopian tube is much more a dynamic organ that we see than what we see. So this is the importance of fallopian tube. So when the tubal tube becomes damaged, that is when there is a compromise of the tubal function. So this can occur after external or internal injury, inhibiting the normal transport of gametes. So the overall prognosis for fertility depends basically on the insult and how much is the severity of the tissue damage. So this assessment it plays an important role in predicting the occurrence of pregnancy and the likelihood of developing an abnormal or ectopic pregnancy. So functional competence of the fallopian tubes implies both tubal patency as well as the integrity of the mucosal lining or the endosalpinx. TFI or tubal factor infertility includes thus an array of disorders affecting one or more of the above components, transient or permanent, and it is manifested by peritubal adhesions, proximal and or distal tubal blockage, or formation of HYDROSALPHINX. So severe impairment of tubal function can occur in the presence of patent tube. Even when the tube is patent, its tubal function can be severely impaired due to the damage to the inner microarchitecture. So as we have discussed, tubal factors accounts for about 20 to 25% of all cases of infertility. It includes cases of completely blocked fallopian tubes and cases where one or either of the tube is blocked, or there is no blockage but there is tubal scarring or any other damages. So you can see in the picture there is a laparoscopy, this finding of HYDROSALPINX. Here the fallopian tube was blocked and dilated with fluid. This is mostly because of previous history of pelvic inflammatory disease. So the most common cause for tubal factor infertility is pelvic infection because such as PID or endometriosis. Endometriosis is the most common and chronic inflammatory disorder affecting around 10 to 15% of reproductive age women. This can also be because of scar tissue that forms after pelvic surgery. So among women with infertility, pelvic pain, or both, the scarring formation is present in around 35 to 50% of women. So PID, as we have seen, PID is the most important cause of tubal factor infertility. So this is because of ascending infections. Most common causative organisms are Chlamydia trachomatis and Neisseria gonorrhoeae. 10% of all cervical infections ascending to the upper genital tract causes salpingitis. So this is the importance of treating cervical infections. In a classic study of women diagnosed with PID, the risk of infertility increased with the number and severity of pelvic infections. So after one episode, the incidence of infertility is around 10 to 12. That increases to 54 to 75% after 3 episodes. So tubal damage from PID causes inflammation and long-term tubal changes such as fimbrial agglutination, fimbrial phimosis, tubal obstruction, HYDROSALPINX, salpingitis hysteria nodosa, and the risk of ectopic pregnancy because of these changes. This can increase to 6-fold to 7-fold after an episode of PID. So coming to the scoring system of tubal damage. So this can be scored in the form of grade 1, grade 2, and grade 3 using the Hull and Rutherford classification system. So grade 1 means filmy adhesions only. Grade 2 is unilateral severe damage and the other tube is okay. Grade 3 means bilateral severe damage. So this is according to the classification system that was discussed in BJOG Journal 2004. So this is an easy chart flow that helps in evaluation and history and evaluation of tubal factor. So if there is any suspicion of uterine abnormality in infertility, it's best to do an MRI or hysteroscopy plus laparoscopy. If there is suspicion of fibroids or endometriosis or HYDROSALPINX, and there is a clear history of chlamydia causing PID, it is best to do a laparoscopy, hysterolaparoscopy, including a dye test. If in a patient of infertility, everything is normal and there is no history of chlamydial PID, you can do a chlamydia antibody titer. And if you find it positive, then definitely we should do a hysterolaparoscopy. And if it is negative, a hysterosalpingo contrast sonograph is enough to assess the tubal function. So coming to the different methods of evaluation of uterine abnormalities. So initially we should assess the uterus and then the tubes. So it will not be, the talk will not be complete if we don't discuss the evaluation of uterine abnormalities. So abnormalities of uterine anatomy or function are relatively uncommon causes of infertility, but this should definitely be included. So the methods of evaluation include a hysterosalpingogram, an ultrasound, sonohysterography, hysteroscopy, that includes the laparoscopy. So hysterosalpingography defines the size and shape of the uterine cavity, and this can reveal development abnormalities like unicornate, septate, or bicornate uterus, or any other acquired abnormalities like endometrial polyps, submucous myomas, which have potential bad reproductive consequences. An ultrasound can be used to diagnose uterine pathologies, including myomas, which are obvious like submucous or intramural or subserous. Sonohysterography involving transvaginal ultrasonography after introducing saline into the uterine cavity. This defines the size and shape of the uterine cavity, and it is used for the detection of intrauterine pathologies like endometrial polyps, synechiae, with Asherman syndrome, and submucous myomas. As we all know, hysteroscopy is definitely the best method for diagnosis and treatment of intrauterine pathology. So this is generally reserved for further evaluation and treatment of abnormalities defined by less invasive methods like HSG or sonohysterography. But ideally, hysterolaparoscopy is the best choice. So coming to the evaluation of tubal patency. So tubal disease is an important cause of infertility, and this should be specifically excluded. The methods of evaluating tubal patency are complementary and not mutually exclusive. Accurate diagnosis and effective treatment of tubal obstruction often requires more than one of the following techniques. So while a full testing of tubal function in patients with infertility is not possible, testing of tubal patency is as important as tubal obstruction is a major cause of infertility. So we should definitely do tubal patency test in every case of patient who comes to us with infertility. So coming to the history of tubal testing, this earlier RUBIN'S test was the only test that was available for tubal assessment. But this has not been done recently because there are newer modalities available. HYSTEROSALPINGOGRAPhy. This is the most commonly used method for diagnosis of tubal factor infertility. So this is an X-ray examination that is performed in the radiology department. Here we introduce a dye that through the cervix into the uterine cavity. The fallopian tubes are open. The dye flows into the tubes and then spills out in the abdominal cavity. So this can be documented with X-ray during the procedure. But this plumbing test does not mean that the tubal function is normal. The inside lining of the fallopian tube can be severely damaged, even though the tube is open and dye spills into the abdominal cavity on the HSG. So open but scarred tubes, that is, the functioning of the tube is not adequate. This may not be able to perform the necessary functions to result in establishment of a normal pregnancy. So proper tubal function allows egg pickup and transport, fertilization, and embryo transport from the fallopian tube down to the uterus where the embryo gets implanted. So even if the egg pickup, transport, and fertilization occurs properly, but the tubal damage does not allow proper transport of the embryo to the uterus, implantation may not occur. And this may get resulted in implanting into the tubes, which will result in an ectopic pregnancy or a tubal pregnancy. So coming to HSG. So HSG is used either as a water, is done by using a water or lipid soluble contrast media. And this is the traditional and standard method for evaluating tubal patency and may offer some therapeutic benefit. HSG can document proximal and distal tubal functions. Occlusions. This can demonstrate salpingitis systemica nodosa, reveal tubal architectural detail of the potential prognostic value, and may suggest the presence of fimbrial phimosis or peritubal adhesions. This is difficult to pick up in a HSG, but still we can when the dye escape is delayed or becomes loculated. So here are some of the observations that we see during an HSG. So this is what we see is a normal, in the left side is a normal uterus showing the spill of dye in the left and the right tubes. The other pictures, that is A picture, will show the unilateral block and arcuate uterus. The other one is a bicornate uterus. And that last one shows bilateral HYDROSALPHINX. So what are the pros and limitations of HSG? This is compared to hysterolaparoscopy, this is a relatively inexpensive OP procedure. As a test for tubal obstruction, it has a very low sensitivity and a specificity compared to laparoscopy and chromotubation. But this is a reliable indicator of tubal patency, relatively poor at identifying causes of tubal obstruction. So this has also got certain limitations in diagnosing tubal spasms and pelvic pathology. So according to the NICE guidelines, HSG should be offered to women who are not known to have comorbidities such as history of PID, previous ectopic pregnancy, or endometriosis to screen for tubal pathology. In women who are assumed to have comorbidities, laparoscopy should be the best choice. So coming to laparoscopy, hysterolaparoscopy and chromotubation, that is a dye test. So the pros are the reference. This is supposed to be the reference standard for tubal factor assessment. Patency, peridiagnostic adhesions, and endometriosis can be assessed. Additional information on uterine malformation, advantages of correcting the underlying pathology can also be done in the same setting. The defects or the cons are it is an invasive procedure, and compared to HSD, it is an expensive procedure also and needs anesthesia. There are there is a little risk of surgical complications, like that is around 1.3 to 1.5%, and there should be availability of operating facilities in the hospital. So there are certain papers that shows whether hysterosalpingogram be a first-line investigation to diagnose female tubal subfertility in the subfertility workup. So what they conclude is that tubal assessment is an integral part for female fertility evaluation. So while diagnostic laparoscopy is a gold standard, it is not suitable to be used as a screening test. So HSG has been advocated as first-line investigation historically. With the advances in diagnosis, more tests are available, such as HYDROSALPINX and chlamydia antibody titer. Chlamydia antibody titer test is a much cheaper, less invasive, and can be performed at any time during the cycle. This can also be used as a means of identifying which patients need further evaluation. It has got and HYDROSALPINX, that is the dye injection test, that is the hysterosalpingo contrast sonography, has the same diagnostic accuracy as HSG without exposing the women to radiation. HSG is supposed to be out of date and has no place in modern infertility evaluation. So coming to salpingography, that is another technique that is used for evaluating tubal function. This is performed either laparoscopically or hysteroscopically. This offers an opportunity to visualize the endosalpinx and diagnose intraluminal tubal damage. The extent of tubal damage may not correspond with that of periadnexal adhesions. There is no experimental studies comparing this approach with conventional methods of tubal evaluation. Coming to HSG, this is that is sonohysterosalpingography. This is an alternative imaging technique compared to HSG. This is an ultrasound-based imaging modality. This permits an accurate evaluation of tubal patency, uterine and ovarian pathology. Use of sonographic contrast medium, example sterile saline or air or COVIST, albinx and infosone. These are some of the contrast media that I used. This is injected into the uterine cavity through the cervix, and this enhances the visualization of the uterine contours and fallopian tubes. So if at least one fallopian tube is patent, then this fluid can be seen in the posterior pouch of Douglas during the procedure. So use of 3D imaging to generate coronal images and Doppler to highlight fluid movement through the fallopian tubes can further improve the diagnostic capabilities of HSG. So we can see the fluid inside the endometrial cavity during the procedure. So here this intrauterine pathology, that is a small submucous fibroid that you can see clearly. The uterine wall and the saline in the uterine cavity is seen as the black space, empty space. A fibroid that is seen in the uterine cavity is seen in the image. So what are the advantages? It is a fast and low cost test that can be performed in an OP setting without anesthesia or sedation. And also there is no risk of exposure to radiation. And it is also better tolerated and fewer side effects. Rated as moderate to severe pain, vasovagal symptoms, nausea, vomiting, which can easily be managed. Serious post-procedure complications like fever or peritonitis occurs in only around less than 1% of the patients. But the sonographic images are inferior to fluoroscopy. Well, let us see some other tests that I use for tubal patency, like saline infusion sonography. This is used to determine the tubal patency, using fluid and ultrasound. Laparoscopy and chromotubation with dilute solution of methylene blue or indigo carmine is introduced via the cervix. This can demonstrate tubal patency or document proximal or distal tubal occlusion. The procedure also can identify and correct tubal factors, such as fimbral phimosis or peritubal adhesions, which may not be identified with less invasive methods such as HSG. So coming to the fluoroscopic evaluation and hysteroscopic selective tubal cannulation. So this fluoroscopy can confirm or exclude any proximal tubal occlusion suggested by HSG or laparoscopy with chromotubation, and this provides the means for correction using specialized catheter systems. So there is this chlamydia antibody test, which is an important test to assess the antibodies. This detects the antibodies to chlamydia trachomatis. That is the most important pathological factor that causes tubal problems. However, This test has limited clinical utility. Compared to laparoscopy, the chlamydia antibody test has lower sensitivity for detection of distal tubal disease. This chlamydia antibody test is a very simple and non-invasive method for assessing the tubal disease. They are blood tests that are used to detect previous infection with Chlamydia trachomatis, which is an obligate intracellular bacteria. This causes PID and subsequent fallopian tube injury and dysfunction. These serological tests may be more suitable as a screening test to classify women into low or high risk groups for tubal disease, warranting further investigation with more invasive tests such as HSG, HYSTEROSALPINGOGRAPhy, or laparoscopy. So, laparoscopy is supposed to be the gold standard in identifying tubal pathology. The nature of pathology can be identified. That this has got a very high specificity, and other associated pathologies like uterine or ovarian pathologies can also be identified. So, tubal and uterine factors for infertility. In case of mild tubal disease, surgery should be offered because it is more effective than no treatment. Proximal tubal occlusions, we can do selective salpingography, hysteroscopic tubal cannulation. Intrauterine adhesions are likely to be, which we can manage this by removing the synechia using hysteroscopic scissors. Salpingography, in case of salpingography, it is always best to do a salpingectomy or clipping prior to IVF because the fluid can damage the embryo implantation. There are some studies on tubal surgery, and we'll just go through this. Glass et al. Reported on 50 women who underwent tubal surgery in the setting of chronic PID. So he had found that those patients who had undergone bilateral reimplantation of fallopian tubes, only one of them achieved pregnancy, which was an ectopic. So although the number of unilateral reimplantations were not reported, but mostly this has got a poor prognosis. And it is better always it is found that it is always better that these patients, we advise them to undergo IVF. So only if there is a normal contralateral fallopian tube, then she has got a chance of achieving a normal pregnancy. The tubal surgery reported on a single case of end-to-end tubal reanastomosis in a patient wanting to reverse that bilateral tubal ligation. The patient became pregnant and the patient pregnancy resulted in a successful term live birth. But usually we see that the reanastomosis, tubal reanastomosis, in case the rest of the tube has got an adequate length and the tubal function is okay, most of the patients get pregnancy. Only if other factors are okay. If she has got a low AMH or there is other male factor, then it is always better that we advise the patients to undergo IVF. A different time for tubal surgery. So that is there was a study which showed a lack of efficacy of tubal reimplantation, and end-to-end reanastomosis is still a novel surgery, novel approach that is performed. But however, in 2019, tubal surgery is becoming rarer due to combination of factors, as we have already told, that because of the success of IVF and the declining infertility providers who are skilled in microsurgery techniques. But it is always better that the patients undergo IVF because the success rate is more. Tubal surgery was on an upward trajectory until the 1990s, and IVF was a force that altered the trajectory and put tubal surgery on its new downward path. So coming to the management of tubal disease. So fallopian tube disease can roughly be divided into proximal tube and distal tube obstruction. Proximal tube obstructions prevent the sperm from reaching the distal fallopian tube where fertilization normally occurs. Distal tubal occlusion prevents ovum capture from the ovary, but can exhibit a range of diseases from mild, moderate, and severe. Mild causes fimbrial agglutination, moderate varying degrees of fimbrial phimosis, and severe causes complete obstruction. So damage to the internal tubal mucosal structures cannot be detected easily, and normal tubal function is difficult to assess. After diagnostic testing has indicated tubal occlusion, interventional radiology and microsurgical techniques can restore fallopian tube anatomy and function. So proximal tubal blockage accounts for 10 to 24% of tubal disease. Selective salpingography is a radiographic procedure similar to HSG, in which the fallopian tube is directly opacified under fluoroscopic guidance. A catheter is passed in the tubal ostium and the radiopaque dye is injected into the fallopian tube to determine patency. This procedure is usually performed by interventional radiologists and has been used to differentiate tubal spasm from true tubal occlusion. So coming to the surgery called tubal recanalization, this is simple and successfully completed in 71 to 92% of cases. Recanalization is possible but less successful in women who have occluded tubes after surgical anastomosis for reversal of a tubal ligation. Microsurgical proximal tubal anastomosis has been largely related to historic surgical interest because it is associated with very low success rates and risk of corneal rupture in pregnancy. So this should only be considered if IVF is not an option for the patient. Coming to distal tubal occlusion. Distal tubal occlusion accounts for most tubal occlusions and infertility. Microsurgery can treat most cases depending upon the degree of occlusion. Unfortunately, salpingostomy yields low long-term pregnancy rates of approximately 20 to 30%, 1 to 2 years after surgery. Low rates, but the rates always varies considerably depending upon the extent of tubal damage and other clinical factors. Ectopic pregnancy rates after salpingostomy from around 4% to 25%. Varying degrees of fimbrial disease can be laparoscopically treated with fimbrioplasty and fimbrolysis. Fimbrolysis means separation of the adherent fimbria. Fimbrioplasty means correction of phimotic but patent fimbria. So fimbrioplasty is done in patent fimbria, but it is phimotic. Surgical success is inversely related to the severity of disease. So distal tubal occlusion, fimbrolysis means, as we have told, fimbrolysis refer to the separation of adherent fimbria. Fibroplasty means correction of phimotic but patent fimbria. So surgical success is inversely related to severity of disease. For mild forms of distal tubal occlusion, the pregnancy rates have been reported to up to 60%. But success rates are lower at 10 to 35% for women with severe tubal disease. Most of the pregnancies occur within the first 2 years after the surgery. There is absolutely no role for surgical intervention in patients with proximal and distal disease because the live birth rates are invariably lower than 10%. So in those patients with proximal and distal tubes, it's better we consider IVF. So this is a method of correcting the phimotic fimbria using laparoscopy. So coming to HYDROSALPINX. So what HYDROSALPINX does is it causes an adrenergic denervation and thus subsequent disturbance of ovum myosalpingeal transport. This is the reason for the poor pregnancy rates in HYDROSALPINX. So distal tubal occlusion from salpingitis or extrinsic causes may lead to formation of HYDROSALPINX either in one or both tubes. So this has got a negative effect on pregnancy and on IVF success rates. Although the hydrosalpingeal fluid does not have direct toxic effects on the human embryos, leakage of the fluid into the uterine cavity may compromise implantation through decreasing the endometrial receptivity and mechanically washing the blastocysts from the endometrial surface. This is the reason why hydrosalpinx causes to implantation failure. So treatment options for hydrosalpinx. One is drainage, neosalpingostomy, salpingectomy, and proximal tubal occlusion. The least invasive of these options is transvaginal needle aspiration of hydrosalpinx under ultrasound guidance. But we have seen that there will be often rapid reaccumulation of fluids. So the Cochrane studies has concluded that laparoscopic salpingectomy should be considered before IVF for women with communicating hydrosalpinx. Meta-analysis of 2 laparoscopic proximal tubal occlusion studies also found improved odds of clinical pregnancy. Thus, both salpingectomy and proximal tubal occlusion are recommended for the treatment of hydrosalpinx before IVF embryo transfer. Coming to sterilization reversal. For those women who want to conceive post-tubectomy, there are 2 treatment options, either IVF or tubal reanastomosis. So, what is the advantage is that it has got there is a chance for natural conception and there are lower risks for multiple gestations. Disadvantage is that the proximal tubal scarring from the surgery itself, delay in attempting conception, and higher risk for ectopic pregnancy and need for future contraception. So tubal reanastomosis is traditionally achieved by laparotomy after laparoscopy assessment. But nowadays we do laparoscopic microsurgery for tubal reanastomosis. So if one or both fallopian tubes are judged to be repairable, then the occluded ends of the proximal and distal segments are opened and the ends are anastomosed with fine non-reactive suture. The prognosis for achieving live birth after tubal reversal depends on the patient's age, the type and location of the sterilization procedure, and the final length of the repaired fallopian tubes. Better success rates are reported in younger women with no other infertility factors, and sterilization is performed with ring or clips. Systematic review failed to identify any trials comparing IVF versus reversal of sterilization. So we should always consider the age of the patient, the type and site of anastomosis, and the final length of the repaired tube. So in case of relatively minor tubal damage, it can be difficult to be certain that the infertility problem is solely because of the tubal factor. So in IVF for tubal infertility, there may be other significant contributing causes that are resulting in the problems. In general, standard infertility testing is performed on all couples, and if no other cause of infertility is found, the presumptive diagnosis can be a tubal factor. However, if the degree of tubal scarring is very minimal, the diagnosis of unexplained infertility could be warranted. As IVF success rates have improved dramatically over the last 20 years, IVF has become the mainstay for treatment of tubal infertility. So IVF is a treatment option for that bypasses the tubal problem instead of attempting a repair. An ART procedure has improved over the past few decades. Almost all causes of infertility, especially tubal factor infertility, have been treated through ART techniques. When IVF, with IVF, that's a procedure that is explained, that is sperms are mixed together in the laboratory, and then the resulting embryos are transferred to the woman's uterus. So success rates in women under 39 are usually very good because these women are relatively unlikely to have additional infertility problems. So whom all we should consider for direct IVF? So who are older, who have severe tubal disease, who have severe male factor infertility, and couples who may want only one or two children should be counseled towards infertility management with ART. Patient preference, religious beliefs, cost, and insurance reimbursement also play a role in the management. So the advantages are good per cycle success rates. It is less surgically invasive, and attempts at conceiving can be started immediately. The disadvantage is that there are risks of multiple gestations, ovarian hyperstimulation, and the cost factor. So when deciding on the treatment of tubal factor infertility, the important factors are patient selection and the number of IVF cycles available. The serving study for peritubal occlusions, proximal tubal occlusions, low-grade disease, and reversal of clip sterilization, number of operations can be reduced, repeated attempts at conception allowed, and good live birth rates are achieved. This must be balanced against the risk of OHSS, that is ovarian hyperstimulation syndrome, multiple pregnancies, and the fact that at present, many women have fewer cycles of IVF due to cost constraints. The prognosis should be individualized, taking into account local experience and the age of the patient. So tubal reversal versus IVF, we'll always vote for IVF. So what are we'll see the advantages and disadvantages. The time of work, that is when she can go to resume her works, is in IVF it is 1 to 2 days. In surgery, she'll make around 5 days to maximum 2 weeks. In IVF, she'll require injectable medicines. In surgery, there is no medicines. Multiple office visits are needed in IVF. And time after procedure, whether the procedure is successful, is around 2 weeks in IVF. And surgery, it needs 1 to 2 years. So success rates, factors that determine the success rates in IVF are female age, quantity and quality, the status of the tubes, success rates at the specific IVF clinic. At some centers, 60%, as high as 60% embryo transfer procedures are positive for young women under the age of 35. So surgery depends upon the tubal surgery and the type of tubal damage. In mild tubal damage, around success rate is around 40% after 1 year, and severe tubal damage only around 10%. There is risk of tubal pregnancy always high in surgery, that is tubal surgery, or the risk of tubal pregnancy is always high, and risk of multiple pregnancies are always high in IVF. So the factors influencing multiple pregnancy rates are the number of embryos transferred, the age, egg quantity, quality, and success rates of the IVF clinic. So how can we reduce this? This is by transferring a maximum of 2 blasts. We can eliminate triplets. And if no wherein, okay, adverse perinatal outcomes in IVF is that perinatal mortality, morbidity, preterm delivery is very low and low birth rate, birth to infants because of prematurity. There is a slight increased risk of IUGR and congenital malformations. So challenges of evidence-based approach to tubal factor infertility. The most important is there is lack of evidence. The diagnosis of tubal factor infertility is influenced by the nature of the test that is used. So difficulty, there is always a difficulty in comparing the outcome with IVF because we can't compare the same patient whether she had undergone tubal surgery or she had undergone IVF. We can't compare the maternal age and the cost effectiveness of the treatment. So key factors regarding the evaluation of tubal factor infertility. Evidence-based underpinning interventions for the diagnosis and treatment of tubal factor infertility is limited and mainly reliant on observational data. Despite the absence of data from randomized control trials on current pregnancy and live birth rates associated with IVF, suggests that this is the treatment of choice for older women with moderate to severe tubal factor infertility. Selective salpingography or hysteroscopic cannulation of the tube is useful in confirming true proximal tubal obstruction and may have a role in treating this condition. Risk of ectopic pregnancies is relatively high following both IVF as well as ectopic. It is always high in tubal surgery compared to IVF. There is need for more trials of surgery versus IVF and of alternative surgical techniques in mild tubal disease and post-tubal sterilization. Thank you. Thank you so much for your patient hearing.
Thank you, ma'am. Thank you for your time. I guess the way you explained in detail, it was more than the content which has been there. It was very informative. Ma'am, we have one question.
Okay.
Question is, tubal block with the etiology of tuberculosis, who has more than 35 years.
Okay.
What would be the first criteria to consider, whether IVF or surgery, or first the after TB medications?
First, we should always rule out genital tuberculosis. That is whether it is post treatment. That is whether she had undergone a treatment for genital tuberculosis. If not, then post treatment. She has finished the treatment. Can you hear me? She has finished treatment for a genital tuberculosis. Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah, she has finished treatment for genital tuberculosis, or we have diagnosed it. Okay.
She has finished the tubercular therapy for 9 months.
Okay. So the first thing that we have to do is a hysteroscopic evaluation.
Yes, ma'am.
Hysteroscopic evaluation, because most of the these patients will have some synechia inside the uterus, and if it is there, then we should always do a hysteroscopic removal of the synechia and see that whether the endometrium is okay, and we should always rule out residual, that is the endometrium may still be having some evidence of infection. After that, it is always the results are always better with IVF. I would definitely go for IVF, because that will be the best for the patient.
Ma'am, we have only that question.
Okay.
And I hope the one who have answered, asked the question, got their answer. And thank you for your time, ma'am. I hope this lot of webinars which she'll connect in future too. And it's a pleasure that you are connected with us.
Thank you. Thank you.